It's a real honor and a pleasure to be here with you all at the AGM. Thank you for the invitation. I am a consultant neuropsychiatrist working at St George's, and at St George's we have recently opened a multidisciplinary Huntington service, and we are a year into running that service now. Previously, I did a PhD at Queen Square with Sarah Tabrizi, and my interest was the neuropsychiatry of Huntington's disease. I'm also, that is relevant to this talk, I'm also the co-lead for the traumatic brain injury neurorehabilitation services at St George's. And hopefully why that's relevant will become important a bit later on. So I'm going to talk about mental health and Huntington's disease. And obviously, I think, just before I start, I just want to say, obviously, this is a sensitive topic. And it's a topic when you ask, the community about the symptoms that are sometimes the most challenging, mental health symptoms often rise to the top. So I just obviously, by the nature of the talk, some people might hopefully not find it too upsetting or anything like this, but just to flag, obviously, we will be talking about some mental health issues and mental health symptoms. So, the talk is loosely broken down into 4 sections. I thought I'd give you a sort of a summary overview of some of the common mental health symptoms in HD. I'm going to talk a bit about treatment options. And then I'm going to give you a few general pointers from my experience, both as being a consultant and when I did the neuropsychiatry clinic at UCL as well. And I'm going to sort of finish really on a big caveat that I really want to try and stress in this talk. And then the last slide, really, it's not really a section, is the future and the challenges in this space. So the picture that I put up was of George Huntington, who obviously wrote the famous monograph describing the condition. And he obviously made a number of astute observations. He said that it's a disease that typically comes on in adult life, talking about the sort of age of onset and things like this. He outlined his theory about it being hereditary, and one of the things that he noted was that it was associated with mental health problems. So even from the earliest descriptions of HD, there's been this relationship, an entwined relationship between Huntington's and mental health problems. And as we know, Huntington's is also a condition that is associated with movement symptoms or motor symptoms, obviously excessive movements, but also sometimes slowing. These include issues with, say, swallowing or balance, etc., and cognitive symptoms. And by that I mean thinking, changes in the way that we sort of think and process information, and alongside that, psychiatric symptoms. So I'm just going to touch on some common psychiatric symptoms that I see in clinic. I'm going to give you just a few snapshots. I've tried to keep my slides pretty clean with only a few points per slide, but obviously if anything's not clear, then do feel free to ask. The important thing to say, though, is that each of these different symptom clusters, they don't exist independently from one another. And one of the fundamental roles of somebody looking after somebody with Huntington's disease is to understand how these symptoms interact. And we're going to touch on that as we go through. So there is an added layer of complexity, which is that, these different symptoms can sometimes look like each other. And so the other thing I'm going to do in my talk is just highlight some of the things that I find useful in clinic when I try to distinguish psychiatric symptoms in Huntington's disease versus other things that are going on. So common things are common, and in psychiatry, depression and anxiety are some of the commonest syndromes that we see, and unsurprisingly, some of the commonest symptoms that I see in my HD clinics. There's also, we'll also talk a bit about obsessions and compulsions, psychosis, apathy, and irritability. So when we think about depression, so obviously Depression is a mood disorder that is characterized by low mood, a loss of enjoyment, and a loss of energy. Very classically, there are obviously other symptoms, but those are the sort of common, the core symptoms, if you like, of a depressive disorder, which is a mood disorder. It's quite common in HD. It can often precede diagnosis, and there's no clear sort of gender difference between who gets depressed and who doesn't get depressed in HD. And sometimes when I see patients in clinic, they might describe to me, say, a loss of motivation or a loss of energy. And it's important for me to try and understand, is this depression or is this something else? And so what I've done here is I've broken some of the symptoms that I find particularly helpful in trying to understand if someone is depressed versus, say, other things that might be going on. So on the left, things like low mood, when people feel down and sad, when there's a clear loss of enjoyment for the things that people used to find joy from, when people get stuck in negative thinking cycles about themselves, negative thinking patterns, that's always a bit of a flag for me. And one of the commonest ones I see, unfortunately, in HD is low self-esteem. I see it very frequently. Other things are a little bit more complicated. So loss of energy could be because of a variety of reasons, due to, say, appetite or other medications or things like this. Again, loss of motivation, and we'll speak about apathy in a bit of detail in a little while. Other things that we call biological symptoms, by that I mean changes in sleep and changes in appetite. These things can happen in HD. That may be unrelated to depression itself. And obviously hopelessness is a concerning symptom for me anyway, and it's a sad state for people to be in, and it's something I try very hard to get them out of. But the route to feeling hopeless at times doesn't always come from being depressed, although it's obviously one of the symptoms of depression. So these are a few sort of things that I look out for when I try to say somebody with Huntington's has a comorbid depression. If we think about anxiety now, again, anxiety anxiety is really a terrible condition. Actually, I think it's underappreciated. I don't think people really understand how severe and how distressing a sort of true psychiatric anxiety disorder is. I think they are also under-researched, and our treatments are not quite as our understanding of how to manage them are not quite as sophisticated as some of the other conditions in psychiatry. And I see anxiety fairly commonly in HD, and it's not always a psychiatric condition. I think that's the other important thing to say, is that sometimes anxiety and low mood, I should say, and actually many of the things we're going to talk about today are common features and experiences of human life, especially when you're going through a particularly difficult time in your life. And it's, again, common. It's common at the time of testing, unsurprisingly, and there's no sort of a clear pattern that I can see from the literature. But again, sometimes it's quite difficult to unpick what we mean by anxiety in Huntington's. And so, often if we take Huntington's out of the equation, people with anxiety disorders might describe, say, muscle tension, restlessness, feeling sort of unsteady. They might have what we might call autonomic features, such as a raised heart rate, sweating, etc., etc. And I don't find these symptoms to be particularly helpful in terms of understanding whether this is an anxiety problem versus something else. Obviously, specific phobias or fears, a generalized free-floating anxiety, I think, is quite important to understand. So if people wake up and feel anxious pretty much throughout the day without clear triggers, obviously there's a difference between feeling anxious about getting a test and anxious about your relative or other symptoms versus, say, just having a free-floating ongoing anxiety. Again, just like with low mood, there are classical thinking patterns that we see in anxiety. So often people will see I might see people who catastrophize. So things rapidly spin out of control. They go to the worst case scenario very quickly. And sometimes they might actually have panic symptoms, and their anxiety might also lead them to be avoidant of certain behaviors. So again, these are kinds of things that I sort of watch out for in clinic, where there's other things like, for example, restlessness or muscle tension or racing heart rate and palpitations. I think those can be, there can be a range of different things, again, because the symptoms, they do interact. I mentioned about obsessions and compulsions in HD, and it's related to anxiety. And I think one of the key things that I try to understand in my clinic is the difference between what we might truly call obsessions in psychiatry versus the idea that versus things getting stuck, ideas getting stuck. So it's not uncommon for me to see patients where thoughts are going around and around, they're just not able to shift away. And that's a slightly different thing to an obsession or an OCD-like symptom. So what we might mean by an OCD-like symptom is, for example, people get intrusive, sometimes disturbing thoughts, scary thoughts, but the key thing that emerges after they get those thoughts is this overwhelming sense of anxiety. This sense of anxiety then leads them to do a behavior, which we would call a compulsion. So you might be familiar with people with OCD, say, turning light switches on and off or washing their hands, but sometimes just repetitively reassurance seeking could become compulsive because it relieves the anxiety temporarily, but then you get stuck into a cycle because the behavior has been reinforced because you've done something, the anxiety's got better, but then you get this thought again and you go round in these loops. This would be a more of a classical obsessive compulsive loop. But sometimes what I see in my clinic isn't exactly that. It's this this type of idea where the thoughts are sort of on a train track, and we've sort of maybe lost the ability to switch trains off the tracks, maybe because of the underlying process or for whatever reason. Thoughts keep sort of going round and around and around, and we might call this perseveration. And these are not necessarily associated with anxiety, but they could look a lot like obsessions. And so these are the kinds of things that I try to sort of unpick, but they're very, they do come up from time to time. So we've spoken about common things. Again, common things are common. Depression, anxiety are very, very common. And when we talk about these other things now, sort of irritability and apathy in particular, one of the key things is understanding that, just checking that things like depression or anxiety are not there, that don't need treating. So irritability is a very common and controversial, not controversial, but I think it's an upsetting symptom in HD. It's sort of, people feel like they're walking on eggshells. They might be a bit more fiery. They might say things, they might have they might be associated with verbal aggression or physical aggression. My philosophy in clinic is that I don't think that irritability is a good diagnosis. I think it is an end symptom that can be arrived at through one of many different mechanisms. So low mood, pain, substance use, anxiety, and delirium, hunger, especially if people are in the later stages of the condition and they're not able to eat properly. Also thinking outside the box, is irritability a condition, is irritability a trait in someone's personality that's been there for a long time, that's maybe exacerbated by the stress and the difficult process of going through a diagnosis or something like this, right? So I don't consider irritability in HD to be a particularly useful diagnosis, because I think I've seen people get to be irritable through so many different mechanisms and means that I always try and explore other things. Psychosis, so by psychosis we mean so there are psychotic disorders in psychiatry, the commonest ones being, say, schizophrenia and delusional disorder and things like this. So this is when people have firmly held fixed beliefs or experiences that other people sort of don't share. So for example, with hallucinations, people might hear voices talking to them that other people can't 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 sort of hear. And the one thing I just really what I always say to medical students to try and get them to understand psychosis is two things. I mean, one thing, sometimes people can have ideas that are quite bizarre and sort of don't make sense, and sometimes carers can struggle to, or professionals can struggle to understand why people just don't think that this isn't possible or isn't true. And what I tend to do, I won't do it here because I'm scared of the technology, but what I do with medical students is when I teach them about psychosis, I play a song on my phone that they can't see, but they're hearing this song while I'm talking, and even though they can't see the phone, they don't know where it's coming from. This song, they shouldn't be hearing Michael Jackson in a medical student lecture. There is no doubt in their mind that this song has the quality of reality, is based in reality, right? So there is this powerful, so these experiences, psychotic experiences like hearing voices or having delusions and ideas, they have this underpinning of reality, this sense of reality, which is absolutely critical. So that's why when I do see patients with psychosis, it's not really about challenging the psychosis, because it's like, would be like me trying to challenge you about the sound of traffic outside your window, even if you can't see the car. I try to work with patients to get them to a point to understand how psychosis is affecting them, their carers, and use that as a way to sort of get to treatment options. And sorry, just to clarify, I don't see it very often, I must say. It's not something that I don't consider. It does happen, obviously, it does happen, and it needs treatment, but in many cases, not all cases, but in many cases, but it is relatively rare compared to some of the other things we've spoken about. And I typically see delusional beliefs more than hallucinations, but that's not, that's very variable. And also the other thing I always flag for GPs, for community mental health teams, or anybody with Huntington's who has psychosis, is, again, think outside the box. Don't think that this is all Huntington's. Ask yourself, is there an infection going on? Is there something else going on? Is it a bad reaction to medications, etc.? So finally, I've left apathy to last because I did my PhD primarily around apathy. And apathy is the loss of sort of motivation and self-directed behavior. And it's very common in Huntington's, and it increases as the disease progresses. In my mind, I think it's the most convincing neuropsychiatric symptom that really bears a correlation with disease progression as such, but I'll talk more about that in a minute. Like I said, it's to do with reduced motivation, reduced self-initiation. People might be a bit less concerned about their problems as a result of the apathy. They might also be a bit emotionally apathetic, so less emotionally available. And what is apathy not? It is not, when I say that, so the thing on the top left, when you name as many animals as you can. So sometimes one of the tests we might do in Huntington's is a fluency test. So we ask people to name animals or words of a certain letter. It's not, and by that I mean the sort of cognitive or thinking problems we see in Huntington's. So apathy is not a thinking problem. It's not the loss of doing things because you can't plan or do things in that sense. That does contribute to what looks like apathy, but I don't think that's what it is. It's not low mood. It's not periods where people are incredibly sleepy or there's a change in consciousness. And importantly, and quite difficult at times, it's not the opposite of irritability. So some people might think you can be apathetic but not irritable, but that's not true. Sometimes these symptoms can coexist. I won't go into too much detail, but my PhD was about apathy, and I published a paper last year looking at how certain brain network changes might put people at risk of developing apathy in Huntington's. I'm not going to go into this in too much detail, but if you're interested, the paper is there from last year. It's open access. So these are sort of common symptoms that I see in HD. And what about management? Well, when I think about management, I think about two things: safety and symptom treatment. So paramount, and the first thing that's always in my mind, is safety for the person with HD. So that's absolutely critical. That's number one, my number one priority in any situation. So some of these symptoms, like low mood, can be associated with safety issues for the person. Number two is obviously things like safety for carers, but also the other things to think about are psychiatric symptoms can make patients vulnerable. So we have to think about safety from others, and maybe to the wider public in very rare cases, I must say. It's not something that I've seen very often, but also safety due to physical health. By that I mean, for example, if I'm starting a medication for a psychiatric symptom, I have to be mindful of how it might affect physical health and things like this. So safety is the number one thing that I think about. Number two is symptom treatment. Now, the important thing to say is, obviously in medicine, we always try to be evidence-based. I think it's important that we have good data, good trials, to know that we're giving effective treatments that are not causing side effects and that we should be treating. Unfortunately, the evidence base in Huntington's for the treatment of mental health problems is rare. Is poor. We don't have big randomized control trials for how to treat depression and anxiety in Huntington's. But what I wanted to emphasize was that there are treatments that I've used in clinic that have been effective. So there are treatments out there, okay? And the way that I approach it, because the evidence base specifically in Huntington's is not very good, is to do a few things. I always think about non-drug options. So are there other things that we can be doing to help? Where possible, I try to avoid mixing or adding multiple medications and avoid high dose regimes unless there are specific cases where it's indicated. So for example, I saw a case at Queen Square with a woman who had very clear obsessional, truly psychiatrically obsessional symptoms. And there is, in OCD, people do use higher dose regimes to get rid of some of those symptoms. In that case, it worked very, very well. So along those lines, because we don't have the evidence base in Huntington's, I use the evidence base from general psychiatry where possible. So there are large trials of depression, anxiety, psychosis. There are guidelines around how we should monitor these medications and use these medications. And I typically lean on that evidence base in my prescribing where possible. Obviously, carer support is paramount, and I'm going to come on to that in a little while. And a key thing really in our management is to use a multidisciplinary approach involving social care, support, and the community neuro rehab teams. So I'm not going to go into each condition and then talk about the specific the specific treatments, because I don't think that would be particularly useful. But I thought I'd give you a few general points. These are sort of from my experience, but a few general things. The one thing, again, I just can't emphasize this enough, is that these symptoms interact. So one important thing is, before we say that something is a psychiatric condition or a psychiatric symptom, is to understand, is it maybe a change in thinking abilities or skills? Is it to do with the physical health condition? Is it to do with something else altogether? Like I said, hunger, pains, infections, things like that. These are super, super important things to rule out, number one. Number two, symptoms change over time. So the psychiatric and the mental health symptoms do change at different stages of the condition. So it's always worth bearing that in mind. And not all of them, this is really, really, really important, not all of them can conclusively increase as the disease progresses. Some of them do. Apathy in particular is a really striking correlation, but not all of the symptoms do to the same extent. Also, I think that the mental health and well-being of carers is part of the neuropsychiatric care of HD patients. I think it is so important in every aspect. And I think it's obviously some of the fabulous work that the HDA do. We're looking to set up carer support groups at St. George's and things like this. But I think it is part of the mental health sort of syndrome in HD patients. The other thing, and I know this is controversial, but psychiatric problems are common in HD, and I passionately believe that patients should have access to local mental health services. And I've had all kinds of excuses, if you like, from from mental health services, there's no commission services. I've had one person say, or maybe there just aren't any services for these people, or maybe the situation, maybe it's not a mental health condition, or in other cases it's too organic. And I just fundamentally don't agree with this. I think it is a discriminatory stance for mental health services to take. And, thanks to the fabulous work of the HDA, there was a recent debate about Huntington's. And this is a quote from Helen Whatley, who is representing the Department of Health, when Hilary Benn asked her about the exclusion of psychiatric patients from mental health services. And she said that, of course, they should receive mental health care and support, and that she was concerned to hear that people were not receiving these support and were excluded as a matter of policy. I'm not sure what the follow-up from this is, but I think it's really important. And I often reference this quote when I'm talking to leads of mental health services in the region, when I'm trying to sort of advocate for my patients. And finally, this is the caveat that I mentioned at the beginning. I've spoken about this, I've spoken about this psychiatric syndrome of HD, and yes, there is an increase in certain psychiatric symptoms in HD. But if you come to see me in clinic, I am very, very cautious about making arguments about causality. I think the biology of HD is complicated. The biology of mental health is complicated. I find it very challenging. In fact, I don't think I've ever seen a patient where I've said all of your symptoms are quote unquote because of HD. I think that language leads to people being excluded from mental health services. And also from a psychiatric point of view, I don't think it's particularly useful. So this is what we might call a classic psychiatric formulation. So the way I like to think about patients is think about biological factors, psychological factors, and social factors that might be contributing to their distress. Think about predisposing problems, maybe things that happened a long time ago, precipitating things that led to this presentation now, perpetuating things that might be driving it forward ongoing, and protective things. So if we just talk about mental health problems as all to do with HD and because of HD, and we try and fill in these boxes, all we're left with is this, right? All we're left with is this idea that all of this stuff, the anxiety, the depression, the irritability, is all HD. There's nothing I can do about it. And I never write my formulations like this. I don't think it's meaningful. So I've got a little case from clinic. It's not a real case, because I'm aware that there might be patients in our region. It's not, but it's a combination of various cases. But a case of a woman with depression was the sort of inspiration for this case. So obviously she had HD. We know that. She also had, even before the diagnosis, had long-standing issues with self-esteem that had been going on for many, many, many years. Her mother had HD, and as we all know, that's a difficult experience to go through in and of itself. Just before she got her diagnosis, or before she became depressed, she was on a medication called tetrabenazine, which at high doses can increase the risk of depression and aggression and things like this. She was struggling with the diagnosis, and she was having arguments with her partner. She was having balance problems, which was really affecting her ability to do the things she enjoyed. She was also maybe drinking too much alcohol. These issues with self-esteem hadn't really gone anywhere, and she didn't really have a great support network. The good things were that we know from her history that previously she'd been responsive to medications, she was wanting help, and her partner was incredibly supportive, which is often the case in my clinic. So as you see, when you fill this table in, you get there's a lot more meat on the bones. And it also gives us a lot more to do, a lot more to help with. So for example, in this case, I switched her away from tetrabenazine and managed her career with something else. We got her input from the HDA. We helped with education with the partner, and the medication changes helped with some of the irritability. For her balance problems, I referred her to the community neuro rehab team, who helped her with balance exercises and physiotherapy. The alcohol use, I tried a bit of motivational interviewing in clinic, and we're slowly reducing her alcohol intake. The self-esteem, people with HD should not be excluded from psychological therapies like CBT. Obviously, perhaps as the disease progresses, these might get more challenging to engage in. But I think certainly in the earlier stages, I don't think there's any reason why somebody with HD can't benefit from psychological therapies like CBT. The amazing HDA advisors in our region went to see her. We spoke to the GP about social prescribing. In terms of the responsiveness, I was able to make kind of timely medication changes. I managed her in my own clinic, but I was considering whether she needed community mental health support. And obviously for the partner, we wanted to make sure that he had the right support. So when we formulate things like this, it doesn't all become about HD, because there's so much more that we can do for patients with mental health problems. And this is true of irritability, it's true of apathy, it's true of psychosis, it's true of anxiety. I've just picked depression as an example. It's not, this is what I do with everybody. And obviously, I have no doubt that in some time we are going to beat this disease with disease modifiers, and then we will be adding that into this treatment framework as well. So my final slide is obviously for the mental health of treatment HD, we obviously need better treatments and more evidence. I think we need to be proactively co-working with mental health trusts, which is something I'm trying to do regularly in my region. We must make sure that when disease modifiers are available, and I'm sure that they will become available at some point, we must make sure that patients with mental health symptoms are not excluded. We must think carefully about the pathways of getting these drugs to patients. And, I think we need more interest and more education with psychiatrists. And very controversially, I know I don't want to talk Hugh and I out of a job, but, should neuropsychiatrists exist, or should we be training up and educating psychiatrists so they feel more comfortable into looking after their local HD patients? I try to do a bit of both. Obviously, I see people in clinic, but when I refer to my community mental health team colleagues, I always try to educate them and support them. But anyway, so sorry, Hugh, I'm not trying to get us fired. And then finally, my HD journey started with the fabulous Sarah Tabrizi at Queen Square, where I did my PhD. She was incredible support and a real inspiration for my onward journey in HD. And then this, on the picture on the right, is our HD service at George's. We have a consultant neurologist, Marianne Novak, obviously Noino Lahiri, who I'm sure many of you know, is our geneticist. Patricia Ribeiro is our HD CNS, so she coordinates HD care in the region, which is absolutely fabulous. And then obviously now I'm standing at the back, and everyone else is part of our research team.
Thank you so much.
Very much. Thanks for having me, everyone.